of hypertension treatment, what should be the approach in the management of hypertension, when to initiate antihypertensive drug therapy, what should be the blood pressure reduction goals, and in brief about the antihypertensive drug therapy. So here I have referred to the European Society of Cardiology and European Society of Hypertension guidelines for the management of hypertension. Overarching goal in the management of hypertension is to maintain blood pressure less than 150 by 90 mm of mercury and to prevent the occurrence of cardiovascular diseases and other hypertension associated complications. Therefore, early identification, early diagnosis, early and lifelong hypertension treatment helps to reduce mortality due to complications arising from hypertension and helps in improving the quality of life of the patient. Before initiating antihypertensive drug therapy, it is important to evaluate the patient in the following manner. First of all, multiple blood pressure readings are taken in supine and standing position to confirm hypertension. Secondly, history taking and physical examination of the patient is important. Signs and symptoms such as shortness of breath, peripheral edema may suggest heart failure. The patient may complain of polyuria or nocturia, and this points towards kidney disease. Investigation should be performed to identify risk factors and detect target organ damage. For example, fasting plasma glucose and lipids helps to exclude diabetes mellitus and hyperlipidemia. Microalbuminuria and urine examination and rise in serum creatinine indicates kidney damage. Echocardiography confirms left ventricular hypertrophy and reduced ejection fraction is an indication of heart failure. In the eye, examination with fundoscopy reveals the condition of retinal blood vessels. It may show signs of retinopathy and atherosclerosis. Special investigation should be performed to identify the secondary cause of hypertension. For example, ultrasonography of renal blood vessels, renal angiography tests for pheochromocytoma. These tests are performed when indications exist and hypertension is considered to be drug resistant. So this is how the patient should be evaluated prior to initiating antihypertensive drug therapy. Once hypertension is confirmed, treatment of hypertension includes lifestyle modification, which is step 1, and step 2 is initiating antihypertensive drug therapy. So lifestyle is vital in managing hypertension. It helps in reducing the doses and increases the efficacy of antihypertensive drugs. Some of the lifestyle measures are cessation of smoking, reduction in alcohol consumption, restriction in salt consumption to less than 5 grams per day, increased consumption of fruits and vegetables which are rich in potassium and fiber, reduction in body weight in obese persons, reduction in fat consumption, aerobic exercise, brisk walking, mental relaxation are some of the lifestyle measures that are advised for managing hypertension. The decision to initiate antihypertensive drug therapy is on the basis of blood pressure levels, risk factors other than blood pressure, and presence or absence of target organ damage. Considering the blood pressure levels, hypertension is defined as blood pressure greater than 140 by 90 mm of mercury. It is further divided into grade 1, grade 2 and grade 3 hypertension, grade 3 being the most severe form of hypertension with the systolic greater than 180 mm of mercury and diastolic blood pressure greater than 110 mm of mercury. Speaking of the risk factors, some of the risk factors other than blood pressure are smoking, diabetes mellitus, hyperlipidemia, obesity, advanced age, family history of cardiovascular disease and premature death are some of the risk factors that can influence hypertension. So these risk factors have to be taken into account while initiating antihypertensive drug therapy. So depending on these risk factors, the patients are divided into low risk, moderate risk, high risk and very high risk. The high risk category includes patients with left ventricular hypertrophy or diabetes mellitus or mild to moderate chronic kidney disease with GFR greater than 30 ml per minute. So these are the cases that belong to high risk category. In the very high risk category, the patients have severe chronic kidney disease with GFR less than 30 ml per minute, diabetes mellitus with proteinuria indicative of kidney damage, or patients with established cardiovascular disease, for example, coronary artery disease. So these are the patients that belong to very high risk category with evidence of target organ damage. So after considering the blood pressure levels, the risk factors and presence or absence of target organ damage, we can decide when to initiate antihypertensive drug therapy. Hypertension can be classified as optimal blood pressure, normal blood pressure, high normal blood pressure, and can further be divided into grade 1, grade 2 and grade 3 hypertension. Individuals with high normal blood pressure, that is systolic blood pressure ranging between 130 to 139 mm of mercury, and diastolic blood pressure ranging between 85 to 89 mm of mercury, are advised lifestyle changes and blood pressure is monitored regularly. But do be kept in mind that antihypertensive drug therapy should be initiated if the patient belongs to very high risk category. For example, patients with diabetes mellitus and proteinuria, or patients with severe chronic kidney disease or with established cardiovascular disease, for example, coronary artery syndrome. So in these high-risk cases, antihypertensive drug therapy should be initiated even when the blood pressure is in the normal range but towards the higher side. Next, we move on to grade 1 hypertension, where antihypertensive drug therapy should be initiated in very high-risk cases and also in high-risk cases in presence of left ventricular hypertrophy or diabetes mellitus or chronic kidney disease. However, if the patient belongs to low to moderate risk category, lifestyle intervention is advised and blood pressure is regularly monitored. If the blood pressure is not controlled within 3 to 6 months, antihypertensive drug therapy should be initiated in these patients, even if the patient belongs to low to moderate risk category. Next, we move on to grade 2 and grade 3 hypertension. Both in grade 2 and grade 3 hypertension, prompt treatment with antihypertensive drugs is initiated. So now that we have learned what should be the treatment threshold and when to initiate treatment, so after initiating antihypertensive drug therapy, let's see what should be the blood pressure reduction goals or blood pressure treatment targets. It is recommended that the first objective in the treatment of hypertension is to lower the blood pressure to less than 140 by 90 mm of mercury in all patients. And if the treatment is well tolerated, the treated blood pressure value should be targeted to 130 by 80 mm of mercury or lower in most patients. So these are recommended blood pressure lowering targets for any level of cardiovascular risk in established cardiovascular disease, coronary artery disease, chronic kidney disease, or in the patient with diabetes mellitus. So the blood pressure reduction goal should be 130 by 80 or lower, irrespective of the cardiovascular risk. Do remember that in older patients more than 65 years of age receiving blood pressure lowering treatment, the systolic blood pressure can be targeted to a range of 130 to 139 mm of mercury. So this is for older patients more than 65 years of age. But in younger patients, irrespective of the cardiovascular risk factor, the treated blood pressure value should be targeted to 130 by 80 or lower in almost all patients regardless of the risk factors. So now that we have learned about the blood pressure treatment threshold, the blood pressure treatment targets, so let's see what are the antihypertensive drugs that can be used for the management of hypertension. So the first line drugs in the management of hypertension are ACE inhibitor or angiotensin receptor blocker, calcium channel blocker, or diuretic, that is thiazide diuretics or thiazide-like diuretics. As per the guidelines, beta blocker is no longer recommended as one of the first line options, but consider beta blocker in presence of heart failure or angina to relieve chest pain or post myocardial infarction to prevent the incidence of ventricular arrhythmias, or in presence of atrial fibrillations to control ventricular rate. So these are the cases where beta blockers are recommended as the first choice drugs. Therefore, initial combination therapy is preferred in grade 2 and grade 3 hypertension, and in grade 1 hypertension, if the initial blood pressure is greater than 150 mm of mercury, then combination therapy is preferred over monotherapy. Combination therapy helps to reduce the side effects and improve the efficacy of the antihypertensive drug regimen. The preferred combination is ACE inhibitor or ARB with a calcium channel blocker, or ACE inhibitor or ARB with a diuretic, that is thiazide diuretic or thiazide-like diuretic. If the blood pressure levels remain above 140/90 despite 3 antihypertensive drugs, then it is said to be resistant hypertension, and in resistant hypertension, spironolactone, a mineralocorticoid receptor antagonist, may be added to the regimen, and this improves the efficacy and helps in blood pressure lowering. Also, loop diuretics are reserved for patients with severe chronic kidney disease or in heart failure patients. So, loop diuretics or spironolactone are second-line antihypertensive drug regimens. For additional blood pressure lowering effect, other antihypertensive agents are available. For example, alpha blockers such as prazosin, terazosin, doxazosine. Although these drugs are effective in lowering blood pressure, they have significant side effects. First dose hypotension or postural hypertension is common with these drugs. Then the next group of drugs are direct vasodilators, which includes hydralazine and minoxidil. They are used in difficult to control hypertension and is associated with fluid retention and tachycardia. Therefore, these drugs are used in combination with diuretics or beta blockers to control tachycardia and minimize fluid retention. The next group of drugs are central sympatholytics such as clonidine and methyl dopa. Methyl dopa is the preferred choice in hypertension with pregnancy, and clonidine is associated with significant side effects and therefore it is not used nowadays. So today we have answered certain questions such as why to treat hypertension, when to initiate antihypertensive drugs, what should be the blood pressure reduction goals, and in brief about the antihypertensive drugs. So please like and subscribe to this channel. Thank you for watching.